Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks so much for having me. It is great to be here. So I'm going to go through really just highlights. This is a topic that I could talk at great length about, longer than the duration of this session and probably longer than anyone would want me to talk about. So I'm going to try to stick to the highlights and try to stick to the things that are most clinically applicable. But I'm going to be talking about both TB treatment and prevention, which are two very key topics for people living with HIV. I have an appointment in global health as well. I come to this topic from both a global and a domestic perspective. And I think when we think about our patients, many of our patients are coming from TB endemic areas. They may have received TB treatment in the past or TB preventive therapy. And so thinking about the global context really is local, even though most of us are practicing domestically. These are my disclosures. I've received grant funding from Merck for unrelated research. Thank you to ongoing support from HRSA. So the goals for this talk are to describe key drug interactions between ART, including newer long-acting ART agents used both for treatment and for prevention of HIV. And so interactions between ART and drugs used for the treatment and prevention of tuberculosis in order to design effective treatment combinations, and to also review the timing considerations and adjunctive therapies for treatment of TB in people living with HIV to optimize patient outcomes. So there will be a fair amount of alphabet soup and a few warnings each time I will throw out alphabet soup. You will have these slides for reference. This is what I will be referring to. The key abbreviations I will be using are primarily MTB infection, which is formerly known as latent TB infection. I'm going to use them interchangeably, but if you hear me say MTB infection, I mean what we commonly think of as LTBI or latent TB infection. TPT is the abbreviation for TB preventive therapy, also can be known sometimes as LTBI treatment, so the prevention side rather than the treatment side, and then drug abbreviations and combos. So the principles of TB, considerations for TB in people living with HIV, is that all people living with HIV should be screened for TB. And there's sort of two pathways at that point. If there is TB disease, active TB, they should start TB treatment immediately. If they do not have active TB disease, then considerations for TB prevention should immediately come into play. And in high TB incident settings, this means immediate starting of TB preventive therapy without any additional testing. Once active TB disease has been excluded, all people living with HIV are indicated to receive TB preventive therapy. In low TB incident settings like the US, we would first test for the presence of MTB infection. So using an IGRA, a quantiferon, or a skin test, probably a quantiferon, and would then give preventive therapy if that test were positive. But TB needs to be a consideration, certainly at an initial HIV intake visit and potentially throughout as well, regardless of whether or not symptoms are present. The other principle of TB treatment and TB prevention for people living with HIV is that everyone needs antiretroviral therapy. And the goal of antiretroviral therapy is virologic suppression, which comes into play both with reducing the risk of TB reactivation and with thinking about the drug-drug interactions and how those affect the use of ART. So people with HIV who are already taking ART at the time that TB disease or TB infection is diagnosed should not stop ART. They may need to switch, but TB treatment is never an indication to stop ART that's already been started. And we will also talk about the timing of if somebody is not on ART, if this is a first healthcare encounter, TB treatment for TB disease starts first, ART starts soon, but maybe not necessarily immediately. So the key challenges that come into play with ART and TB treatment primarily derive from the fact that one of the classes of drugs used to treat TB, the rifamycins, so that's rifampin or rifapentine, these drugs induce cytochrome P450, which results in drug-drug interactions with many antiretrovirals. So use of rifampin or use of rifapentine will decrease the level of many antiretroviral drugs that are metabolized through this pathway. And this can result, if it is not anticipated and not prepared for, this can result in virologic rebound with ART becoming ineffective in conjunction with TB treatment or prevention. And for people without HIV who are taking PrEP, use of TB treatment or prevention medications can result in increased vulnerability to HIV acquisition because the levels of PrEP are decreased by the rifamycins. So when there is a case of needing to start TB treatment or TB preventive therapy, there needs to be shared decision-making with patients to determine whether switching their ART regimen in order to optimize TB or TPT options is preferred, or choosing a TPT regimen or maybe alternating TB treatment if that's at all possible, if ART options are really limited and there's not a possibility to switch. So we have some options that allow us greater or less flexibility with both ART on the ART side in choosing flexibility with our TB treatment and TPT options. And similarly, we have certain TPT regimens that are entirely flexible to any antiretroviral. So depending on what's the priority, where there's more fixation or more preference, we have universal TPT options. So I use the phrase universal TPT and universal ART, sort of analogous with blood types. So there's universal donors and universal recipients. The TB preventive therapy regimen that is compatible with all ART is the daily isoniazid. So 6 to 9 months of daily isoniazid can be TB preventive therapy for all ART. All other ART will need to have some adjustments to use with some TB treatment and any other TPTs. The universal ART is a triplet, tenofovir, FTC, and efavirenz, which was very convenient when that was the first-line regimen, but is no longer the first-line regimen. But TDF, FTC, and efavirenz is compatible with all TB preventive therapy and all TB treatment without needing any dosing adjustments. Universal PrEP is Truvada, TDF, FTC. This is compatible with all TB prevention and all TB treatment without any dosing changes either way. All other TPT option and TB treatment combinations with ART are likely to require some ART adjustment if they are feasible. Again, goes back to the rifampin induces P450. The standard first-line ART in most of the world, including here, is a dolutegravir-containing regimen. In most of the world, it's TDF3TC dolutegravir, so TLD. And this means that in order to dose with the INSTI, with the dolutegravir needs to be given BID to be given along with concurrent rifampin-containing TB treatment. The global second-line ART regimen contains lopinavir ritonavir. That is the only protease inhibitor that can be given with TB treatment with rifamycins and also needs to be double-dosed, which has increased side effects. And also as a principle to remember, we can't give TAF along with RIF because the interactions are even less clear. So some ART alphabet soup ahead, now that we've talked about TB. So just going over the first-line ART regimens in the HHS guidelines. So an INSTI with 2 NRTIs, thinking about Biktarvy and dolutegravir-containing regimens. I've tried to color code the ARTs so that the things color-coded in red are a hard stop contraindication with rifampin, rifamycin. The orange color code are drugs that can be given with rifamycins, but will need a dose adjustment. So you can see, although INSTI is first line in all of our first line regimen, of the integrase inhibitors that we commonly use, both bictegravir and cabotegravir are contraindicated. We can use dolutegravir, but again, the dosing needs to be made BID instead of daily. So our combinations of dolutegravir plus TDF-FTC can be given, but dolutegravir is BID instead of once ID. In our guidelines for first-line ART, if there is a history of long-acting PrEP use, boosted darunavir can be used pending results of genotype. However, darunavir is contraindicated again with RIF, so that's not an option. So we have our options for TB treatment are limited to the dolutegravir-containing regimens. Again, just driving home that protease inhibitors, except for lopinavir, ritonavir, contraindicated. For NNRTI class, efavirenz does not have interactions with RIF. Everything else does. I think the biggest sort of new update in this talk is thinking about long-acting ART formulations as they are currently used or anticipated shortly to be used. So we have cabotegravir being used for ART. Both components of Cabenuva, both the cabotegravir and the rilpivirine, are contraindicated with rifampin. So this becomes very complicated if somebody is on cab and needs TB treatment. They will need to be switched to a daily oral ART regimen if they need TB treatment. And this would be, generally people who are on injectable ART are on that because that is the best regimen and administration for them. And so if they need TB preventive therapy, choosing a non-rifamycin containing regimen may be best for them. Lenacapavir, also currently used for ART treatment, long-acting injectable medication, a capsid inhibitor. This also has a hard contraindication with rifampin. So an alternate treatment will be needed if TB treatment for TB disease needs to be used. Long-acting antiretrovirals are also used for PrEP. Currently, cabotegravir is used for PrEP as a every 2-month injectable. Lenacapavir is expected to be FDA approved for PrEP as a Q6 monthly injection later next month. Both of those, again, are contraindicated with rifampin, so those are not expected to maintain their efficacy for prevention if given alongside TB treatment. So additional oral PrEP options would need to be used to maintain HIV prevention. And similarly, if TB preventive therapy is given, a regimen that does not interact should be chosen. So again, for TB treatment, there's very little flexibility in being able to lose the rifampin component of TB treatment. So long-acting ART or PrEP will need to be switched to daily oral. For TPT, there can be a discussion of risks and benefits of what patient preference is for switching injectable ART or PrEP versus choosing a TPT regimen that does not interact. And I've tried to put these into a usable table to show which TB treatment regimens can be given with which ART regimen. So there are 2 main TB treatment regimens that are used. There's the classic 2 months of 4 drugs, the RIPE therapy, followed by 4 months of 2 drugs, 6 months of daily medication. There is now also a shorter 4-month regimen that is many of the same drugs as the original regimen, but uses rifapentine instead of rifampin and uses moxifloxacin instead of ethambutol. It's a 4-month daily regimen, and they both have similar interactions with ART. So the recommended ART to use if TB treatment is being used is either TDF-FTC and BID dolutegravir, or 3TC with BID dolutegravir, or TDF-FTC efavirenz. Those are the same for both of those regimens. Thinking about TB preventive therapy, we have many options for TB preventive therapy. We have increasing numbers of options for TB preventive therapy, which is great for our patients both with HIV and without HIV on PrEP vulnerable to HIV acquisition who may have TB exposures or need TB prevention. Quickly going through the TB preventive therapy regimens we have, I've again color-coded these. I really like color coding. Everything with orange in it is a rifamycin-containing regimen, which means there are going to be some interactions with the antiretroviral therapy. The one TB preventive therapy medication that, again, it's our universal TPT, no interactions with ART, is the isoniazid, so that's in blue, it's not in orange. So we can see that there's no change to ART. Isoniazid can be given either 6 months daily or 9 months daily. It is no longer the first-line preferred TB preventive therapy for anyone because of concerns about hepatotoxicity with long-term use. It's one of the longer regimens, so it's harder for people to finish, and the hepatotoxicity accumulates over time. So if it is possible to give a shorter rifamycin-containing regimen, that is better both for patient safety, likelihood of completion, efficacy is similar. So isoniazid is at the bottom of the list because it is the least preferred, but is often the only option if ART options are limited. The first-line preferred regimen is true first-line preferred is 3HP, which is isoniazid and rifapentine, which is given for 3 months, once a week. And this has multiple compatible ART options that are given without interaction or without dose adjustments. So one of the reasons this is preferred for people living with HIV, A, is that it's shorter, easier to complete, but it can be given with TDF-FTC dolutegravir or 3TC dolutegravir or TDF-FTC efavirenz. So all of these are options that can be given without dose adjustment of the ART, just given with 3-HP. All of the other regimens that contain erythromycin will need to have some adjustment to the ART, usually making the dolutegravir BID, unless it's a TDF-FTC efavirenz that is the agreed upon ART regimen. So the other, just to quickly summarize the other TPT regimens, there's 3HR, which is 3 months of daily isoniazid rifampicin. There's 4R, which is 4 months of daily rifampicin. And then this is an alternative, or we're accumulating experience with use, 1HP, which is 1 month of daily isoniazid and rifapentine. This does require, again, ART adjustment because it's daily rifapentine instead of weekly rifapentine. So the advantage is that it's short. The disadvantage is that it does still require an ART adjustment. So principles are key, just remembering that switching ART is a vulnerable time for loss of virologic control. So if considering a switch in ART in order to give TB treatment or in order to give TB preventive therapy, ensuring that the patient is able to be supported to maintain good adherence with the switch, figuring out how complicated is the switch going to be. For example, just switching Descovy in the regimen to Truvada, that's an invisible switch. They're already taking one, they switch to another. That's a pretty easy switch to make without many implications for patient and pill taking. But going from a single pill ART regimen to a regimen that is 2 pills and one of them is BID, that's a little bit more complicated. So really discussing risks and benefits with the patient about what's going to work best for them. If patients are highly treatment experienced and not suppressed, their ART options may be really limited and they may not have a switch option, in which case thinking about how to minimize interactions with TPT. This is the similar table of TB preventive therapy medications along with PrEP and considerations for PrEP. So again, with TDF FTC PrEP, no changes need to be made for any of the TPT options, which is fine. Isoniazid, no changes need to be made to PrEP, but also remembering that TAF FTC and long-acting PrEP are okay. They're compatible with isoniazid. So if that's the PrEP option that's working best for someone who needs TPT, isoniazid is the way to go. Thinking about when to start TB treatment is really important for people with HIV on ART, and the evidence went back and forth for a while till we had accumulating evidence that for people who have very advanced HIV disease, CD4 count less than 50, there is a mortality benefit to starting ART very shortly after starting TB treatment. So within 2 weeks for people with CD4 less than 50. For people with CD4 greater than 50, starting TB treatment immediately and then starting ART within 8 weeks has the similar effect, and there's no additional mortality benefit to pushing that ART start earlier. Overall, the idea is we should start ART as soon as feasible for patients, because we know that the sooner people start, the more stably they're able to get on treatment, become virally suppressed, have their immune system able to fight the TB as well. However, taking into account concerns about drug-drug interactions between TB and HIV, side effects, adverse effects with having multiple medications at once, having the evidence that for people with CD4 higher than 50, there is that flexibility to wait until some of the side effects are sorted out before initiating ART. All that being said, I always emphasize with this slide that for CD4 less than 50, it start TB treatment immediately for everyone. ART should be started within 2 weeks, and it doesn't mean it has to wait for 2 weeks. So it's really 2 weeks is the upper limit of when it should be started in terms of mortality benefit. So it's never wrong to start ART earlier. It may be more complicated for the patient, but mortality outcomes are better with an earlier start. There are a few considerations for additional treatment for TB and HIV when treated together. So again, for people with advanced HIV, CD4 less than 100, and they not yet started ART, the PredArt trial showed that people who are given empiric steroids at the time of TB treatment start and ART initiation have reduced immune reconstitution syndrome and have reduced total levels of steroids that are given throughout the course of their early TB treatment. So this was a study done in South Africa, but then the evidence is now part of the US guidelines as well. So the conditions for starting empiric low-dose steroids to prevent IRIS are that person living with HIV, CD4 less than 100, there's no RIF resistance in the tuberculosis, there's no KS, and there's no Hep B virus. There are a lot of other studies being done to try to improve TB treatment for people living with HIV, especially people with advanced HIV disease, because TB remains an incredibly highly morbid and fatal disease, highest cause of mortality for people living with HIV. So we are still accumulating evidence on whether things like increasing the RIF dose at the beginning of TB treatment may have some advantage. If doing truly simultaneous treatment may have some advantage, but that is evidence that is still to come. So stay tuned.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.